So neurological emergencies, and the first thing we'll talk about under here is headaches. So these are a pretty common reason for people to come to the emergency room, right? I know sometimes it seems like a lot of headaches come to the ER, but actually it's not as many as you think. You know, abdominal pain is actually your #1 reason for ER visits. And so one of our jobs as far as headaches go is to try and make sure there's not any more serious condition going on with these, right? So looking for pertinent signs or symptoms or findings or history that suggests there's a bigger problem. Most of the headaches are going to be pretty much benign and not a life threat for the most part. And there's different pressure receptors, different pain fibers that can fire just depending upon what's actually causing the headache. Most headaches, when you actually look at all of them across the board, especially the non-life threatening ones, are going to be a lot more into the soft tissues like the scalp muscles, like our tension headaches or our stress or our contraction headaches, or vascular. Now, as far as most vascular ones are actually not strokes, so we're not talking about hemorrhages, but migraines. Migraines make up a large number of typical migraines are actually vascular mediated. So that's just showing you some of the structures involved that could be involved with some of these headaches. Now, when we talk primary versus secondary headache, a primary headache means it is the primary problem. In other words, these tend to be mostly chronic. There's not just a one-time fix for them. There's not, I can just, suddenly make you better and never comes back. These tend to be recurrent. The word secondary means they're secondary to something else. If you fix the something else, the headache should go away. So if they're having meningitis, we treat the infection, give them in the hospital some antibiotics, the headache should go away. They're having a new brain tumor or whatever, get that image, give them admitted and referred to neurosurgery, deal with the brain tumor, the headache should go away. So it's just the phraseology means primary means it is the cause, secondary, it's secondary to something else. And those should be like a one-time deal for the most part. This list of headache red flags, you do not need to memorize it for the exam. Just be familiar with, you should be able to look at this list and say, yeah, I can see each of those things is possibly related to a more serious problem. So in other words, our run-of-the-mill day-to-day migraines, tension headaches, sinus headaches should not have any of these findings with them, okay? If we have any of these findings, and that tells us we probably need to do more of an evaluation, maybe some imaging, some other testing, things like that to focus that in. And these are all, when you look at these words legitimately, they're all pretty serious findings. I do want to point out the thunderclap. If a patient says, describe their headache, it feels like something just exploded or a bolt of lightning went off or something like that, that should get our attention for things like subarachnoids, our bleeds, etc. And for some reason, it's just one of those words the patient tends to pick a lot of times. I don't know why they, decide to say it, but that legitimately describes what it feels like to them. So let's look at our different headache types here and talk about what characterizes which ones and what makes them different, or how to differentiate between them. Now, the nice thing about the exam, of course, is there's no drug seekers. The patients they present us will follow the textbook descriptions. They're not going to give us like any mixed type headaches or mixed presentations. Because that's not fair test questions, okay? We need to be able to at least pick out the ones that are straightforward and we can easily identify. So your typical textbook migraine will be one-sided. That's key right there, okay? And usually they also have the nausea, vomiting, the light and sound sensitivity as well. Cluster headaches, this describes that their pattern of their headaches comes in groupings. They actually get a headache and it goes away, a headache, it goes away, a headache, it goes away. And then at some point later, be hours, days, or weeks, that same grouping of those headaches comes back. So sometimes this patient doesn't know they have cluster headaches until they've kept like a headache diary at home. And between them and their provider, they're able to say, okay, we see these clusters here, you've got a cluster headache diagnosis. Now, these are going to be one-sided also, and the pain tends to localize around the eye, like the periorbital area, maybe down kind of behind the eye as well too. You see here under the frequency that it's variable. Now, that being said, each patient tends to have their own frequency and duration that they can recognize. Now, between two different patients, they may have a completely different cycle or cluster of headaches, but each one has their own unique pattern. And that helps the provider when they look at these headache diaries and such, kind of pick this out and say, yep, it's probably cluster headaches. Now, tension headaches, these are pretty straightforward. Most of us have had these at one time or another. Very common, usually not something most of us go to the ER for, usually not that severe. But this will be bilateral. So the migraine, the cluster headache are unilateral. This is bilateral. And they're going to use words like tight, squeezing, feels like there's a band or something constricting around their head. And that has to do with those scalp muscles being either tight or inflamed or fatigued or whatever. So bilateral, and should not have the migraine features of that nausea, vomiting, that light and sound sensitivity. Now, temporal arteritis, this is one that's actually built up over time. Not that they've had the headache over long term, but the underlying problem, which is the inflammation of the temporal artery, takes years to build up. We typically don't even think about this in someone under 60, okay, just because of the time of onset takes to build up the inflammation. But at some point, it's going to cause some pain, and it's going to be just one-sided. I mean, could you have temporal arteritis of both temporal arteries? Well, sure, it's possible because you have two of them, and let's face it, inflammation and atherosclerosis doesn't always just pick one side. But the presentation, the textbook presentation, will be one-sided, and it's going to be very tender, right over that temporal artery. So you palpate their scalp, their face muscles, whatever. They're going to tell you, ow, it hurts right there when you press on it. So the concern here is the potential for blindness, because that temporal artery feeds the optic nerve there. So that's actually, of course, we treat to alleviate the pain, but we want to prevent complications also. Okay. Because of the inflammatory process that underlies this, we're going to get a SED rate. And that's going to be one of the tests that, of course, SED rate measures inflammation, and this is an inflammatory process. This is one of the few times that we don't, for the most part, I'm going to say about 80% of the time, and during the course of all the lectures, I usually point this out, SED rates and CRPs are usually interchangeable. There's a couple times that they're not. This is one time you're going to prefer a SED rate or a CRP for sure. Okay? And again, in the real world, day to day, about 1 out of 5, the SED rate's normal, but it's still the most useful test we can do to diagnose there's inflammation going on. And for the CE exam, it would be elevated. They're not going to throw that curveball saying, well, it's not elevated, and everything else points towards it. Because of the inflammatory nature of this, it needs steroids. So you can expect to be giving them some prednisone if they can take PO, or Solumedrol if they got an IV in place already. Of course, some pain medicines. They're going to confirm this at some point with a temporal artery biopsy. Now, that does not need to be done inpatient. If the patient's stable, they look good, they're not toxic or anything, they can go home and they can be done as an outpatient. But that is the perfect test, because they actually do a little punch biopsy of the temporal artery and send it off to patho and look for those inflammatory cells there. These are just some triggers. A lot of these are related to our migraine patients or some of these chronic recurrent headaches. And some of the patients already know what their triggers are, or the consequences, or the symptoms that are manifest. Sometimes we have an opportunity to kind of educate or reinforce these things with them. You know, for example, if you drink, 6 Cokes a day, you still go down to 0, you might have like some caffeine withdrawal kind of headaches. Maybe the patient doesn't realize that, and we might pick up on something to kind of help talk to them about and educate them. Menstrual cycles, interesting. A lot of GYN doctors understand this relationship between hormone cycles and imbalances and migraines. And sometimes they'll offer to put their younger females on birth control, not just for birth control, but also to help to balance and regulate their hormone cycles more reliably. And a lot of girls that have chronic migraines, doing that helps to minimize the frequency or even the occurrence of them. So just looking for some of the things that might trigger these. Migraines are a disease of triggers, by the way. And there are a few others that we talk about during the course of lectures. I point them out when we come to them. Just if I haven't mentioned already in another section, asthma, migraines, sickle cell are probably the top 3 diseases of triggers that you're always looking for that trigger also to try and prevent that from happening. The physical exam. So we're not really doing full neuro assessments yet, like stroke scales, because we've kind of already figured out this is more of a primary headache, more of a recurrent one based upon the symptoms. So we're just doing like a general assessment for the most part. But we're going to also kind of focus in the assessment a little bit more based on what we suspect. So for example, if I think it's like a sinus headache, they're probably gonna have some frontal pain. It might be kind of tender when we kind of tap on their forehead or their cheekbones around their sinus area. If I'm thinking, possibly something infectious, and especially in our kids, I need to get them undressed and look for like rashes and such. It might be associated with meningitis. So lab testing. So this will help, again, kind of narrow down and confirm our diagnosis even more. All right, so if let's say we're really suspicious for meningitis, well, you can expect a spinal tap to be part of that, or lumbar puncture. If we're thinking it's that temporal arteritis, I got a female, 75 years old, one side pain, I can expect at least a SED rate to be ordered in that patient. Of course, probably some other labs, but the most useful one will be that SED rate to rule that in when it elevates with the inflammation. And then the big question about CT scans, so it seems like we just give these away to everybody, right? This slide is really close and really similar to that red flag slide I had a few minutes ago, because again, we want to have a reason for doing the test. What we don't want to do is just be doing shotgun workups to everybody, or just, well, let's see what we find, let's see if there's anything there. We want to have a short list of what we really suspect is going on. We want to be able to say, I'm doing a CT scan because I'm suspicious for a subarachnoid. I'm doing a CT scan because I'm suspicious for some type of brain cancer or some type of new mass growing in there, something like that. So if I don't have any red flags, I don't have the sudden onset, I don't have the elder person, I don't have the trauma, none of these things that could signify a significant problem, then I don't need the CT scan. And you don't need to memorize this list, but again, look at this list, you're like, yeah, I could see that some of these things could be a more serious problem. So if I do suspect the meningitis, then we can expect that spinal tap is going to be done. One of the things we might notice on the spinal fluid is if it's bacterial, is the glucose may be a little bit lower than normal, because bacteria have to eat, and so the CSF glucose will be consumed some by the bacteria. If it's a viral meningitis, usually that glucose count is normal. Sometimes we have to do a spinal tap to really make sure we've ruled out a subarachnoid. Maybe the subarachnoid was so early or so small that the CT scanner didn't pick up on it. If there is a small subarachnoid, there will be microscopic red blood cells on that CSF, because the CSF circulates in the subarachnoid space, and that's where the blood would be. So sometimes, occasionally we'll do that to confirm. We'll do the other stuff first for stroke stuff, like scans and whatnot, and stroke scales. But if we really just, man, it really sounds like a subarachnoid, but the scan's negative, and these focal deficits, we might do a spinal tap to really look for the red blood cells. Then we got to pick some interventions or some medications, and ideally always try and treat the cause specifically to resolve it. Sometimes fluids will be part of this. Remember, one of the big reasons for headache visits to the ER is things like migraines, and dehydration can be one of those triggers for that. So sometimes fluids will help with that. And also fluids might actually prevent or make it less likely that if we give some strong medicines, it's going to drop their blood pressure. Some specific medicines to talk about under headaches. So if we really think it's a migraine, ergots would be the go-to drug for these. They work on that vascular part of the migraine response. They actually help to relax that vascular irritation. We do want to be careful if they have a strong heart history, because sometimes the ergots can trigger some coronary spasm. So, look at the age and the risk factors of the patient. If someone's 55 years old, 60 years old, they got 10 stents in their heart, cholesterol medicine, blood pressure medicine, aspirin and Plavix, and all these screaming cardiac risk factors, ergots may not be the one to go to, because it could trigger some coronary spasm as well. Now, compazine, we use this for migraines sometimes. It does help with a little bit of sedation. Of course, helps with the nausea too. And sometimes for migraines, we need to break that cycle with a little bit of sedation. That's useful. It does have the side effect, and this is more the better word for you than what's in the book there, akathisia. So the word dystonic means, that's in the book, just so I can define it because it's there, I'm going to change it. Dystonic means dysfunctional contraction. And that's the key, is it actually contracted. So we see this more with the psych medicines, where they might come in like a day or so after getting Haldol or any other antipsychotic, and their neck is tight and drawn over. That's a dystonic reaction. The thing with the compazine and Reglan and possibly Phenergan, because they're all in the same family, phenothiazines, is actually akathisia. And that's that restless feeling. They just can't sit still. They got to keep moving. They're up and down to the point sometimes they're like, I'm ready to go. Just get me out of here. So that's possible with all three of those. Phenergan is very rare though, but because all three of these are the same chemical structure, it is potential. How do we fix this? Benadryl, okay, diphenhydramine. Sometimes, particularly when I'm ordering compazine or Reglan, I'll order Benadryl, or I'll order Benadryl with it just to prevent this from even happening. Some providers will kind of wait and see what happens, because it can be pretty heavy sedating if you give the Benadryl and the compazine together. but just know that Benadryl is it's not really an antidote. It's a known side effect of these medicines that can happen in some people. Toradol, so a pain medicine, it's a non-steroidal. So if I got little granny with her, possible creatinines like 1.8, 1.9, maybe not ideal for her because I don't want to stress her kidneys. But the nice thing about Toradol is that it should not sedate your patient. Okay, now if you walk in after giving it and they're like snoring, they might be snoring because they finally got some pain relief. All right, so, but it should not make them somnolent. It should not make them drunk. They should still be able to, if they get to go home, drive themselves home from most places. And then you got other choices for nausea medicines too, Zofran. We talked about the Reglan, the Phenergan also. We'll talk about opiates last, because obviously if I give an opiate, not that it's wrong, but I'm going to have an altered neuro assessment on this patient. And that's one of the things with these neuro emergencies is we want to be able to do repeat assessments to notice if there's any changes, either improvement or especially if it's trauma, excuse me, that there's not any decline. So it'd be our last drug to go to, but at the end of the day, we do need to treat the pain. I mean, that's why they're there. And because it's a CEN exam, there's no drug seekers there, right? All of the painkillers, all the narcotics, all the opiates have the potential for some hypotension. That just kind of goes with the territory, so we want to watch for that. So sometimes we'll make sure we have some fluids running, possibly. And of course, give the lowest dose necessary to get them some relief there. Most of us have gotten away from Demerol. Demerol will just totally snowball somebody. You can forget doing any neuro checks with that. There is a slight risk of seizures with Demerol when we're using it a lot more often, or some patients are getting like repeat doses. They come with their headache, every week kind of thing. Or even in a PO form on an outpatient setting, it does lower the chance, it does lower the bar for seizures. So I think most of us have moved away from using Demerol. I know a few places, and what I see is it's typically more smaller community-based hospitals where they got like the old family practice doc who's moonlighting or something like that. Most of your younger guys that are emergency trained providers have moved away from it quite a while ago. And then Rocephin will be the last drug we talk about. Of course, this will be specific for meningitis. It's very effective for the meningitis germ. And the concern of Rocephin is it comes from the cephalosporin family, and there is a potential cross-reaction with penicillin. It's actually a very, very small number. And in general, if your provider is truly more concerned about meningitis and there's a question of a penicillin allergy, they're probably going to go ahead and give them medicine. Now, if the person says, yeah, I had penicillin once and I turned blue, I stopped breathing, they had to give me epinephrine IV, no, we're not going to take that chance with Rocephin. But for the most part, it is pretty safe to give, and we're going to err on the side of we need to treat the infection as best we can there. So on the exam, they would not put you again on a balance beam. Well, was that really an allergic reaction to penicillin? No, they'll give you someone who had a true anaphylaxis. And you'd be like, nope, we need to pick something besides, or hey doc, let's change that order. Or hey doc, did you realize that she wound up getting intubated with her anaphylaxis to penicillin? So again, the disposition, the teaching points, and the discharge stuff, so that back into the nursing process as we're winding up this patient, get him out of there, get admitted, whatever. We have some opportunities to educate. So I showed you about the slide about the possible migraine triggers, maybe some opportunities to reinforce teaching there with them. As far as med administration, some of our chronic migraine patients have home medicines they can use. And a big thing with that is to help remind them they need to take these things early. If they have them at home, take them early for them to, it's not that they won't work, it's just they're more likely to work if they take them like within the first couple of hours versus waiting a whole day. Especially those ergots we're talking about, like the Imitrex or the Rail Packs they may have at home. Our stroke patients, so this of course is more of an emergency problem, more of a significant thing. Strokes do have a significant impact on our healthcare and overall debility and long-term deficits with some of our patients. So it's pretty important that we look for these. And I think most places have really ramped up in the last 10 years, these stroke protocols, these stroke pathways, these stroke alerts, things like that. And it is a big push and big metric. And there are some core measures that our hospitals and our ERs strive for to meet and do good quality stroke care. So we're talking about some impairment to blood flow or oxygenation to the brain tissue, whether it be a blockage or something's not letting it get there, like, and we call those ischemic, or if it's a hemorrhage, we have our ruptures, our aneurysms, our subarachnoids, etc. But the end result is the oxygen is not getting to the brain tissue. All your risk factors for stroke are very similar to your cardiac risk factors because it is considered a vascular disease. And let's face it, again, atherosclerosis doesn't just say, hey, I just want to go to the heart. If you've got some coronary disease, you've probably got some vascular disease in the brain vessels. You've probably got some vascular disease in the peripheral extremities too, that PAD, that peripheral arterial disease. So the risk factors are very similar. The most important thing we want to know about the stroke is what time did it start? Okay, because that's going to start a lot of our metrics and our timers as far as our interventions and our time guidelines to get things done. Now, if we don't know the time it started, then we want to know their last well time. So I'll tell you what's not in the exam is you will not be treating the patient who, some places will treat these wake-up strokes, assuming the possibility that it actually started, just before 5 minutes before they woke up. Some places don't do that. So that's not a universal right now, all right? If they woke up with stroke symptoms, then we're gonna go backwards and say, okay, what time were you normal before you went to bed? And in other words, we're trying to be the most protective as far as because the thing, we don't know when it started, especially if they're sleeping like for 8 hours, because if they're sleeping for 8 hours, and unless it happened mid-sleep from 4 hours forward, they're outside that TPA window. So the universal CEN question, if it was a wake-up stroke, is when were you normal before you went to bed? And we're going to use that time. And we can have many different symptoms. Of course, the ones that come to mind most often are like the one-sided weakness, the speech problems, the comprehension problems, but it can be as subtle and as isolated as just double vision or diplopia. And sometimes even it presents as vertigo, okay, that dizziness. And we're recognizing that more often now. And years ago, people come with vertigo a lot. We give them some antivert, they'd be better, send them home. Nowadays, we're like, no, vertigo needs to be recognized that it could be a sign of a cerebellar stroke, that's the back of the brain, and that posterior circulation. And a lot of times they're getting evaluated based upon risk. Now, a 20-year-old having vertigo, probably not doing the same workup as a 70-year-old female that has diabetes, also other vascular disease, things like that. She's definitely getting more of an aggressive workup, the older one. And again, just tying in their medical history, looking at all the risk factors here, okay? Migraines can be a stroke mimic. There is a subtype of migraine where it's actually a vessel spasm and it clamps down, and that clamping down, that spasm of the vessel can actually obstruct the blood flow. So you can actually get a type of hemiplegic migraine. It presents just like a stroke, but in addition to the stroke symptoms, they're having this excruciating migraine headache. That's one of the clues there. Usually, unless it's a subarachnoid, a stroke does not cause a significant headache, okay? That should not be a typical migraine headache with stroke symptoms. That makes you think there's something else going on, like an atypical migraine. Our diabetics, of course, they're also at risk for vascular disease. And if someone's had a stroke or a TIA before, we're always going to watch them a little closer and maybe even prioritize them a bit higher, because no matter how well they take their medicines, see the neurologist, they're always at a slightly higher risk of it happening again. Now we're going to start doing more of a specific neuro exam in these patients. So they come in with whatever their symptoms are. It's looking like a stroke. Maybe we call it a stroke alert. We're going to do more than just a general neuro check. We're going to focus in, look at some specific things unique for that stroke that might present. One thing we might see is that blood pressure going up. It is now known that part of the brain's ischemic response is trying to jack up the blood pressure to perfuse it more or perfuse it better. So a lot of times, so it's not necessarily that the blood pressure was the cause of the stroke, okay? But it could also be that the blood pressure is in response to the stroke, trying to perfuse the brain tissue. Now, the NIH scale is the generally universally accepted scale. Every place I've talked to is using it. I know there may be other quick scales places use or EMS uses, like Cincinnati pre-hospital, the LA pre-hospital. Of course, those are pre-hospital. There's some other ones, but the overall majority, I'm gonna say greater than 80–85% of ERs are using an NIH scale or one that's very close to it. Now, for this exam, you do not need to memorize the points. like how you score it, but you do need to be familiar with the things that we look at on it. And I think if you just slow down and thought, you could say, yeah, we check something with the eyes, we check the mouth, we do the smile, the wrinkle of the forehead, we have them read some cards, read some words off, we have them look at a picture, and then we do this thing with the arms and the legs, you know, see if they keep them up, if they keep them held up. We check their sensory. So you can, what you do need to know for the CEN is the different parameters we look at, but you do not need to know, okay, that's a score of a 3 or a score of a 2 for whatever, okay? None of the scales I've ever seen on the exam, whether it be GCS, APGAR, NIH, RTS, trauma scales, none of those have you ever had to calculate, but you do need to know the things that are being looked at. Sometimes these stroke patients, we might notice they're AFib, and maybe they're not anticoagulated with Coumadin or one of the newer medicines, or it could be a first-time AFib where their last EKG was normal when they were chest pain 2 years ago, but now we've got AFib. That could be their risk factor for what's going on now. So we decide this is a stroke, we do a quick assessment. We need to start doing some things very quickly. These are a few of the numbers you do need to know for the exam. You do, because this is a national standard. You do need to know that they need to get to the CT scanner within 20 to 25 minutes of showing up. So we need to do this very promptly. Now, if there's an airway problem, then we do have to deal with that first, but we still want to try and get there in 20 to 25 minutes. All right, so if we do need to secure an airway, we want to make sure to get our good airway person there to do it. Let's go get it on first try so we can get them to the scanner still very quickly. And then the next number you need to know is the 40 to 45 minutes. So this is one that's going to go to the top of the radiologist work list. He probably knows it's a stroke alert, or the tech is going to tell him, hey, I just sent you the scan for a stroke alert. Make sure you read this. And they're going to call your ER attending or have some process to notify them the results of that. Again, airway is a priority. So if their mental status, their GCS is anything less than 8, which is only about half of normal, your normal GCS is 15, we might need to intubate this person first. But again, we want to do this quickly so we can still get them to the scanner in time and still address their stroke, which may be the reason for their respiratory or breathing issue, right? 2 IV sites, because some of the medicines are not compatible. And for the stroke, we're going to be careful with the fluids because there can be some cerebral edema with the ischemia of the stroke. And I don't want to put a leader in this patient, all of a sudden this brain starts swelling, and now I've got too much. We talked about RSI under respiratory, so we're not going to do it here, but just know this may be the time to make sure that we have our best person, our best attending, if you have more than one ER doc or provider, in charge of this airway. Not the new guy who just got out of residency and just passed his boards or whatever, maybe, but someone that's pretty skilled in it. We're going to look at the vital signs. Now, we want them to stay below 185 over 110 to be TPA eligible. That's actually a product label from the FDA for our TPA. All right. So we're going to use then these two medicines, the labetalol and the cardine, are pretty much standard across the U.S. Now, you may only have one of them on your stroke pathway or on your doctor's order set, but both are approved for use for acute stroke management. Labetalol, of course, is a beta blocker, so we need to watch the heart rate if we're given that one. And then cardine is a calcium channel blocker, so it doesn't really affect the heart rate. The nice thing about the cardine is it's a drip, so you can titrate it. We prefer that where I work. We've used the labetalol sometimes. I don't like it because it seems like you have to keep giving it like every 10 or 15 minutes. But you do need to know the 185 or 110. So circle that, highlight that. So we've got a person who meets the time window. We got them to the scanner in 20, 25 minutes. It got read within 40, 45. Their blood pressure is below 185 or 110. There's no contraindications of TPA, so we're going to give this. Now, the metric that Joint Commission and American Stroke Association looks at is to give it within 4 hours of onset, okay? If you can give it within 3 hours, that's the best outcome. So in other words, if your patient comes in at 2 hours after onset, and it was, let's say it was witnessed by the spouse at home, and so we have a definite time of onset, and they present 2 hours after onset, we don't want to have the mentality like, okay, we got 2 more hours to get this drug to them. We should look at like, okay, if we can get it in the next hour, by that 3 hour window, they're going to get the best outcome and the lowest chance of any risks. Okay, so 3 hours is best care. However, your metric is set for 4. There's no question about the 4 to 6 hour window or the extended window on the exam, because not everybody does that. That's very facility dependent, based upon your neurologist, your ER director, your medical staff committee, your pharmacy. Those people would have decided if your facility is doing an extended window and the secondary criteria. So that won't be on the exam. For the exam, you'll see the 4-hour window. And if the exam says anything about giving it less than 3 hours, go for it, because you're going to get really good, you can get a lot better outcomes. You do not need to calculate the dose for the exam. Again, there's not a lot of calculations on the exam at all, maybe 2, and this is not one of them, okay? But you do know that this is one of our high-risk medicines, so if you're not verifying it with the pharmacist or whatever, there's usually 2 people involved. Where I worked last as part of the stroke team, I would have my paper and I would calculate it, and then the neurologist would have his, he'd calculate it, we make sure we got the same number. And a lot of times the pharmacist who would show up also would do it with us, so we'd have like a triplicate check. This is a picture of a perfusion scan, and I put this in here to show you what they do at the bigger facilities, the ones that receive these stroke patients for like definitive intervention care, the ones that are doing the thrombectomies, the ones that are doing the vascular interventions, the ones that are basically doing a brain cath, those places at those tertiary centers. What they're doing is a perfusion scan, and what you see here, and this is where I worked up in South Carolina, we would do these on arrival, and you see the green tissue is the ischemic tissue, the red tissue is the dead tissue. So this patient is not a good candidate for us to do an intervention and do a brain cath, because the amount of tissue that can be salvaged, the green stuff, is much less than the red stuff. So the ideal person has more green than red, more recoverable area. And they call it the penumbra also, the areas that's not dead yet. Some places will do this before they ship them out, and that might be part of the criteria if the tertiary place accepts them or not. If that place doesn't do it before we ship them out, we will do it at the tertiary center as soon as matter of fact, when they come in, like from our smaller sister hospitals, we would go right to the scanner and do this perfusion scan, because the neurointerventionist is like sitting right there tapping his foot going, okay, am I taking them to specials? Am I taking them to specials? Let's get the perfusion scan. So just to show you something that happens on the back side of things, that a lot of times not working at a tertiary facility, you don't see these processes, but that's called a perfusion scan. All right, after they have their stroke, of course, they get admitted, they get some rehab, some recovery, maybe they got TPA, etc. But their long-term care, just like someone's had a heart attack, they're going to be on antiplatelet medicine long-term, trying to protect that vasculature, reducing the risk of clots down the road. So aspirin is, of course, very popular. Plavix is probably number 2. Ticlet is hardly used much anymore, but it's still an antiplatelet. So those are 3 of the common ones. The exam would not ask you about Ticlet. It's not that popular, but I think you guys already know that either aspirin or Plavix would work for this as far as maintenance goes. And if they present with a TIA and they got better, even in the department, depending on risk factors, age, other conditions, things like that, they're probably getting admitted, because a third of TIAs will have a full stroke within 90 days if you don't find out what caused it in the first place. It truly was a warning sign. Okay, they just got lucky that it resolved. When I first started in emergency nursing 20 years ago or so, we'd send them home all the time. Oh, you got better? Well, here's some aspirin, call your doctor. I think what you're seeing now is at least these people come in for an overnight stay or like a 23-hour or an observation admission, like a short admission, to get some tests done and find out where the risks were. All right, changing it up a little bit. To dementia now. So this is not as obviously high speed or as emergent as a stroke is, but it is a reason for neuro presentations in the ER sometimes. And this is actually changing it's actually dysfunction of the brain tissue over time. So it's a chronic process, and its memory is usually what's affected. Now, short-term memory first. Now, there's a lot of people in the community that have dementia and do just fine as long as their family kind of keeps an eye on them at home, the spouse looks after them, etc. They do fine. For this exam, being as a CEN exam focuses on emergencies, the presentation will be someone that already has dementia, but now something different is happening, something more dramatic, like they're being violent or agitated with the family, or they're so confused they don't recognize them, or they're doing something really unsafe, like they were found walking, 2 neighborhoods over, wandering, confused, things like that. But a big thing with dementia is their mental awake state does not get affected. So they should not be sedated. They should not be somnolent. They should not be difficult to arouse or lethargic. It's just truly an information processing problem, not a mental status problem. The risk factors for dementia, a lot of these are just damage that builds up over time. Repeat head injuries, all right, all these boxers, football players, all that. There's some tissue changes that's residual with each of these traumatic head injuries they have. Of course, Alzheimer's is a type of dementia, and not all Alzheimer's progresses. Some of it just stays with the forgetfulness, but a true dementia can ensue in some of these patients. And then sometimes we're dealing with multiple med lists, right? Some of these meds are causing more problems, and sometimes that's what's leading up to the dementia-like process. And of course, that's not usually something we can fix right away in the ER, but hopefully their primary doctor or their neurologist, whoever they're seeing, looks at their meds and says, hey, maybe we can try coming off this and see if it doesn't improve this possible dementia going on. But dementia is a diagnosis of rule outs, meaning we have to exclude all the things that could be causing this behavioral or cognitive change. And then these things should all be negative. Okay, because we can't test for dementia. Let's look what we can test for and make sure that's not the problem. So this patient will be getting a pretty big workup in the ER. And if they get admitted, the hospitals will be doing some other special stuff too, like the vitamin levels and different electrolytes. For example, what's one electrolyte we look like in the ER? Well, sodium. A very low sodium can cause confusion, seizures, disorientation, things like that. Sometimes these elders have some occult, meaning hidden or not obvious, sepsis, and they can present, like a dementia thing. So their workup should come back negative. The CN is not going to ask you, is there a specific workup you do? Just know that we're going to be looking at all these different causes that might show up on a test for altered thought processes. Now, if we find something, we'll fix it. So we find that hyponatremia, we'll treat that. If we find that sepsis, we'll treat that. And that should fix this presumed dementia presentation. At the end of the day, the tests are going to come back negative, and it boils down to treating the symptoms. So either something from the anti-anxiety family, like our benzos, or our antipsychotics, like the Geodones, the Respratols, the Haldols. It's going to be up to the provider to pick which one they like. But you should be able to at least recognize you're going to expect to see a medicine order from one of these two families or combined. And again, you do not need no specific agents. So do we need to admit these patients? That's always a question. Here's how you look at that. If someone was already on some dementia medicine and they had, quote unquote, a normal breakthrough or exacerbation, we ruled them out, for other things, give them some meds in the ED, they got better, they went back to their baseline, we probably could send that one home because they're already being treated for dementia. Now, if it's a new onset, they probably need to be admitted, because if they're not on these psych medicines, let's be honest, we don't know that a new prescription of Geodon 20 twice a day is going to work for them. It probably needs to be titrated in a monitored setting or in a supervised setting like a hospital. So that's kind of how we look at this. And then of course, we also have to defer to what's their care setting at home. If the family's very uncomfortable, they think, nah, he's not really back to his normal, or we really think it's too unsafe, we kind of need to listen to that and defer to that. So a lot of things have to be in place to send a dementia patient back home. We got to rule out the possible causes, treat what we see, and then, can they go back to their baseline, and are they safe back in their normal environment? All right, VP shunts. So this will be one of our pediatric topics in this exam. And as I say in other lectures, there's about 10 or 12 peds problems. Now, an adult can have a problem with this too, but it's not the usual presentation. Usually it's presented as a child, okay? And this is a child who's had, at birth or shortly thereafter, they found that they had too much CSF being produced. And so therefore, their ICP was going up from this excess fluid. So they put this tube in, which is just a drain, to allow the fluid to drain down into the abdomen where it's reabsorbed. So we can have one of two problems with this. It can either be blocked, and so therefore the ICP is going up because the fluid can't drain, or it can be infected because it is an implanted medical device, and any device has a potential for some pathogens or emboli to get on it. So either obstruction, either not functioning, or infected. So of course, we're going to ask the history questions. Tell me about the child, their past medical history. Have they had problems with this before? What do they present like if they had problems with it before? And you're usually talking to a special needs caregiver the child has special needs, and their caregiver or their parent usually is pretty in tune to their symptoms and their unique presentations. So they're going to be a very good ally to help you get this history and really listen to them, because they know the little subtleties, little nuances that this child probably has. And a lot of these are not old enough to give their own history. You have to get it from an adult. So the physical exam will tend to reflect what the problem is. If it's a problem with it functioning, like it's obstructed or it's out of place, we're going to see the neurological changes from the ICP going up. If it's a problem with it being infected, we're going to tend to see more of an abdominal presentation, because that infected fluid or the pathogens on the tube are migrating downwards. So they're probably going to show up with a tender belly, a warm abdomen, febrile, etc. So again, back to the two main problems: either obstructed and not working, neuro, or infected, infectious, and usually in the abdomen. So at a minimum, we need to make sure the tube's in the right place. So if we're not worried about the ICP and it's not a neuro presentation, we like to minimize radiation on children. We don't want to just blast them with all these CT scans all the time. If I just need to check placement, make sure it's in the right place, I need 3 X-rays. All right, and in some hospitals, it's packaged as one shunt series, but if you had to order them separately, it would be a skull, a chest, and a KUB. It's just looking at the 3 areas with each picture to make sure, okay, it's in the skull, I see it going down to the chest, and I see it in the abdomen. Now, if I'm thinking it's an ICP problem, it's not working, I need to have the CT scan, because the CT is telling me, is their brain shifting? Is it starting to press away from the midline because of increasing pressure? So an infected shunt just needs the plain X-rays, make sure it's in the right place. If it's a neurological problem, the shunt's obstructed possibly, or it's dislodged, I need the CT also to see if the brain is shifting. And we'll just treat whatever we find. So we find that it's infected, of course, we're going to order some antibiotics on admission, or as soon as they suspect that. If we find that it's not functioning, then there'd be a consult to peds neurosurgery, or transferring like to a children's hospital or something where they do these things. And a peds neurosurgeon is obviously going to put them on the surgery list to take it out, revise it, fix it, whatever it is they do with those. Seizures. So this is a temporary change in some movement, sensory, or cognition. It's basically the neurons are firing in an uncoordinated fashion, causing what we see. The only seizure on the exam will be the grand mal or the typical epileptic seizure, because it's the only one that has the emergency of status epilepticus happening. Okay, all the other ones, the partial, the Jacksonian, all those are not an exam because there's no emergency with them. Okay, I mean, yeah, we treat them. Okay, but there's not an emergency condition that you die from a partial seizure or a focal seizure. When you look at all the different types of seizures, most of them will fall into one of 2 groups. Either our young children under 2, of those being febrile seizures, or the over 60, 65-ish group where you got things like strokes, you got vascular problems, you got your diabetic problems, like if they drop their blood sugar, it looks like a seizure. All right. So actually the smaller group of the typical epileptics is usually somewhere in the 30s or 40s, and it's not the largest group out there when you look at all comers. So status is the emergency, and this is when they don't get their effective breathing control. So the pause between seizure episodes is not long enough to get an effective breath in there. Now, it doesn't mean they're completely locked down necessarily, not breathing for 5 minutes, but if their pause is only like 10 or 15 seconds, and they were seizing for like 2 minutes, you need more than a breath or two in those 10 or 15 seconds to make up for what you weren't doing the previous 2 minutes. So it's a very subjective call, but the universal answer is when the pause is not long enough to allow for good ventilation. Now, we don't want to paralyze a seizure patient because it will stop the seizure, but it takes away what we monitor for, which is the seizure activity, the motor of the extremities in the body. All right. But at some point, we might have to paralyze them to control their airway. And that is what we do for status. but we're going to use a very quick acting paralytic so you can actually go back to watching the convulsions and see if they're still there. Now we're going to put pseudoseizures up here for just a minute. They're not an emergency, obviously, but what does make them different? Well, a couple things. Usually start pretty quick, like within a couple seconds, this person decides to have their episode. And they also tend to wear off pretty quick, meaning they go from having their episode to back to baseline very quick, like within less than a minute, like back right up doing whatever they're doing. With our typical epileptic patient, grand mal seizures, those ones usually have that prolonged or protracted post-ictal phase, usually about like an hour sometimes, as they kind of gradually come back to baseline. So there's some ways to tell these apart. We're not going to treat them any differently when they're having their pseudoseizure. We still need to protect them from injury. We still need to assess them for injury afterwards, because sometimes they do get hurt doing these things. And then make sure there's not some other red flag going on here. So getting the history is key for this all. It's like, for example, if someone says, yeah, they were just walking right down the street talking on the phone, all of a sudden they fell out and had a spell, that's not usually the epileptic seizure. That's like more pseudoseizure. Epileptic seizures, they usually know to get themselves in a safe place. Okay, what type of activity was seen? What were the circumstances? Was this a seizure? Within an hour after they had some head trauma, there was a bar fight or something, and then an hour later at home they had a seizure. Well, that's concerning, because that could be expanding hematoma or something from their head trauma. Did they have some fevers and chills recently? That makes you suspicious for things like meningitis. And then what's their other history that's, relevant to this? Do they have a history of seizures? Was this their normal seizure they have? Is it the normal pattern, the normal things that would precipitate it or trigger it? Diabetes, was it a seizure mimic? Like if their blood sugar goes really low, they're hypoglycemic. Sometimes families will bring in their family members. Oh, it's a seizure, and it was just their blood sugar. Certain medicines, things like, you can write this in, Ultram, Tramadol, has been known to reduce the seizure threshold. That's one of the reasons why we're not using it much anymore. Also, yeah, Ultram or Tramadol can potentiate a seizure. So again, I say this time and time again, depending on the circumstances, the risk factors. I know a lot of times, with certain conditions, we just have like standing orders we do for everybody. But we really want to, pick things that are going to help really give us the answers we're looking for. So sometimes it is a shotgun workup. It is a big $1 million workup. If at the end of the day, it's one of your known epileptics and there's nothing in the recent history to suggest a problem, it's not due to trauma, they're not having some infection recently, it may just, and it's their normal seizure witnessed, I may just need to check their med level, like their Dilantin or their Depakote. That may be the only thing I need to do. Okay, but I've got to ask all the questions to see, could this be a sign of something different happening now? So if they're with us and having a seizure and we're thinking about status, our interventions for that, we're still going to try and suction them during those pauses. We don't want them to risk aspirating. Okay, but at some point we may have to actually put them down to get them intubated to protect that airway. So we might have to use RSI with that. And if we do, again, we want to be able to do it quickly, because remember, if we paralyze them, we won't be able to see the seizure anymore. We won't know if our medicines are working as far as seizure control. We need to see that motor activity. Now, this is something we're not using anymore. This is an old school device called a jaw screw. The thought was 20, 25, 30 years ago, if you were clamped down and seizing, we would put this big plastic screw there and start to crank it to try and open your airway so you wouldn't swallow your tongue or bite it. Today, we're not putting nothing in people's mouths. No padded tongue blades, no billfold, none of that stuff, all right? If they're that clamped down, you put something in their mouth, we need to RSI them, put a breathing tube in them, and then go back to work with our sedatives or our neuroleptic medicines. So benzos would be the drug of choice here, because benzos slow down that brain conduction. They kind of reorganize it, because remember, it's firing in an uncoordinated fashion. And any benzo is fine. It just depends on the provider. Of course, things like Versed work quicker than Valium. Ativan's kind of middle of the road. Most of those, we have multiple routes too. So if we don't have that IV yet, most of them we can give IM. So that's a possible alternate. And remember, if we have to drill these patients with the IO, anything go through the IV, Valium, Ativan, Versed, can go through the IO also. So we've got multiple ways to get these meds to them. Benzos will be first line. Second line would be the neuroleptics, okay? You don't need to pick any specific one. You don't need to know any dosages because it's very provider dependent what they want. And of course, there's other ones like Keppra is not up here. Keppra is one we use sometimes. Just be able to recognize that that whole grouping are the neuroleptics. Okay, if this is a seizure patient that gets to go home, so let's say it's not a first time and it's their normal pattern or whatever. So some of our teaching points for that, medicine levels. You know, if they don't already know and they're on something like Dilantin or Depakote, ones that we can measure, you know, they probably need to be seeing their doctor occasionally to get these levels checked, because if the levels go too low, of course, seizures can manifest. If it's a pediatric patient, we're probably having to reinforce about fever control, but most of your pediatric seizures are the febrile seizures. So we're gonna make sure the mom and dad or caregivers have the correct weight-based dosing. Usually most discharge programs in the ERs with the kids' weight in there will actually calculate a dose on the discharge papers for the parents and the caregivers. Driving. So it varies from state to state what they need to do as far as to regain the driving privileges. But what we do know is in the ER, if you've had one, then we need to tell them until you're cleared or whatever it is in your state, or you see a neurologist or you're seizure free, whatever your state says, there's no driving. So they're not going to ask you about how long they can't drive on this exam, but you will know at least from the point of ER discharge going forward for some time, they're not going to be driving. Our ICP issues. So this is the end result of things like trauma, anything causes cerebral edema, anything causes too much fluid to build up, like the obstructed VP shunt or whatever. And that pressure starts exerted on the brain, they're causing problems. Now, the brain wants to maintain this physiological perfusion pressure. That's the amount of driving force that's going to keep the oxygen going through the vessel wall to the tissues. That's what your brain, so your brain doesn't want a certain ICP. Your brain wants a certain perfusion pressure, but ICP is factored into that. And we calculate this perfusion pressure by the mean arterial minus the ICP. You do not need to know any numbers for this for the exam. You just need to understand the relationship, that the MAP, or the average blood pressure, is the driving force, the ICP is the resistance, and we subtract one from the other, you get your perfusion pressure. And that's what the body's actually looking at, trying to regulate. Now, initially, the body can deal with a fair amount of change. As an ICP starts to go up, it can compensate actually quite a bit before we get problems, all right? But when you have late ICP issues, it tends to go like off a cliff, like this graph here shows you. What you see along the bottom, along the left to right axis, is the volume going up with the ICP increasing, but yet the line's really not going up, not elevating a lot yet. But somewhere here, there's a certain point where all this compensation goes away, and just small changes now make it really go higher. And this is where they're at risk for herniating. So the shallow slope on the bottom of the line is your early ICP issue, or ICP time, or whatever. Your right-hand side here, where it's going up like a mountain, like a steep mountain, this is late ICP and risk for herniation. So they can have sudden changes. They're almost irreversible. So we as clinicians, we're going to try and overcome this increasing pressure. All right, we need to do something to increase the perfusion pressure because it's been compromised by either the brain tissue swelling or too much CSF in there or whatever, or a big blood clot expanding. So working the formula, we could increase the MAP, because remember, it's MAP minus ICP. All right. However, one of the problems with doing that is if you give them a big fluid bolus, you're actually putting more substance in there, and that can increase ICP on the backside of that equation. So not always the answer. You know, blood products, again, they just go take up more space. So really working with the MAP is not usually the answer we're looking for here. It's better, more useful to look at getting something out of the brain or out of the skull. Well, we can't take the brain out, we need that. But maybe we can take some of the CSF and some of the water in there out. So that's where we use our diuretic, which is mannitol or osmotrol. And the way mannitol works is called an osmotic diuretic. Hence the word osmotrol is one of its brand names, has that word osmo in there. It's actually trying to shrink the brain a little bit by kind of drying it. So the brain gives up some of its inherent water that's in the cells. So it's a little shriveled, takes up less space. The other thing we do is keep the blood vessels small. I don't want vasodilation in ICP because bigger vessels take up more space. So I can try and constrict the vessels a little bit so they take up less space. And this is one thing I might do with hyperventilation, because CO2 causes vasodilation. So if I drive the CO2 down, hopefully the vessels will be a little bit smaller and take up less space. So hyperventilation is when we increase the rate of ventilation, okay, because we want to get rid of some of that CO2 and shrink the vessels. However, there's some problems with it. It does work, but it's hard to do and get exactly what you want, the exact effect. One of the problems is with breathing more times a minute, that's more times that your jugular veins can't drain out of the head. Because when your chest expands, you take a breath, there's a little jugular venous backflow. So now if you're hyperventilating your patient at 30, 40 times a minute, that's 30 or 40 times a minute that you're obstructing a little bit the jugular flow, okay? So that's kind of a touch and go there. If we drive the CO2 too far down, it might constrict the arteries also. And this ischemic brain with this ICP needs oxygen. So ideally, if we hyperventilate a patient, we just want to get some venous constriction, okay? But if we don't do it just right, we get venous and arterial, and we cause more of a problem. So the current recommendations are, we can consider hyperventilation as a temporary measure because it will work very quickly, all right? And if they're at an ICP place where you're thinking they're fixing a hernia, they're already on a ventilator. So the hyperventilation is simple as just going to the ventilator and changing the rate from 12 to 20 to 24 to 30. And that CO2 will adjust very quickly and start hopefully getting some response. But we can't do it for long term. And it's very unpredictable. So things like putting in a propofol or benzocoma, that's more useful, but that takes time. Things like doing the mannitol, it works, but it takes time. Sticking a ventriculostomy in there takes time. You gotta get them to the OR, things like that. So hyperventilation is a bridge device or a temporary thing we can do immediately while something else is being started up, okay? So it could be like the one thing that saves them from the clutches of death while you're waiting for the mannitol you just gave to kick in, all right? So the more evidence-based, predictable things take time. But hyperventilation is that temporary thing. And again, we're not doing this until late stage to really worry about the herniation. I mean, they may have given the patient some mannitol, 30 minutes ago because they already saw some new brain cancer or swelling, and that's fine. But if you go in the room and the patient's having some dramatic neuro changes, they've gone from confused, anxious to now lethargic and nonverbal, that's that immediate risk for herniation. And we need to respond right now by doing something to change it. Now, when they herniate, this is when the pressure can't be compensated for anymore, and the brain's going to squeeze out through the foramen magnum, and it's going to cause brain damage. The big problem with the herniation is the tissue that herniates, you're not getting it back. It's permanently damaged. And it's got some things like some of your vagus nerve is in there, your respiratory control centers in there. So we start seeing some vital life control processes be affected very quickly. And one of the sets of symptoms or findings for a herniation or an impending herniation is Cushing's response. Now, a lot of books call it Cushing's triad, which makes you think there's only 3 things. There's actually 5. Okay, and this is when I put this class together and I researched all the contemporary books and presentations and things like that. I synthesized, and what I see is there's 2 things everybody agrees on, which is the hypertension and the bradycardia. Hypertension because the ischemic brain trying to perfuse, the bradycardia because it's compressing on the vagus nerve in the brainstem because they're fixing to herniate. And then amongst all the other authors, the other 3 are the things that vary. So for the CE exam, you want to know all 5 of these, okay? Because some of these other authors have also submitted CE questions before too. So we have to consider hypertension and bradycardia, and then possibly irregular respirations, okay? And it can be anything that's not the nice, normal, even 12 or 20, anything. You know the different names for patterns, okay? It could be a wide pulse pressure because as that systolic's going up, trying to perfuse the ischemic brain, the difference between the 2 is getting bigger and bigger. So wide pulse pressure, and then some change of their pupils. It can be one reactive, one not, one fixed, one dilated. Anything that's not the nice, normal, equal pupils, equal round and reactive delight and accommodation bilaterally. Okay, hypertension, bradycardia, irregular breathing, wide pulse pressure, and some pupil changes. The early symptoms of ICP, these are very nonspecific, so sometimes it's hard to pick up on. But this is why we have to do frequent neuro checks, because we want to pick up on these patterns as they evolve. Okay, I mean, there's lots of reasons a person could be anxious. If they're in your trauma room, like, oh, did I hurt anybody? Where's my kid? Does my wife know? Whatever. All right, but when that starts becoming confusion, disorientation, repetitive questioning, slow to respond, difficult to respond, we need to see that progression. So the early findings are very, very vague. Okay. The late findings are very specific. Okay. However, by the time we see late findings, it's like they're fixing to herniate. It's like a point of no return. All right. And again, part of the late findings are the Cushing's response, those 5 things. Okay. The hypertension, the bradycardia, the wide pulse pressure, the respiratory changes, and the pupil changes also. And now we also have our motor posturing, the decerbate or the decorticate. Now, they're actually both bad because these are late findings of ICP, like pre-herniation. So it really doesn't matter which one is better or which one is worse. However, if you really want to split that hair, the decerbate would be, I don't want you to think worse like, oh, if it's just decorticate, they're going to do okay. These people are probably both going to herniate, all right? But a late finding is the decerbate one, okay? It doesn't change our treatment in any, and in real world, they actually go back and forth between these two before they herniate and die. All right, we're going to take a break here for about 10 minutes. Hang on. Our next topic is talking about some head injuries, and of those, the first one being concussions. So this is basically just a temporary change in mental state. They do not always have to be knocked out to make a concussion. Sometimes it can just be like a blank stare possibly. Okay? But whatever the alteration is, the reason this happens is their reticular activating system is basically control-delete the brain. It's overstimulated, the brain shuts down, and just like the computer, when you do this, it's going to come back online. Oops, switch off music, sorry. It's going to come back online at some point. So this is a temporary change, okay? It's not going to be a permanent change, temporary. We actually only really get concerned about whether they're unconscious or not because it helps with medical coding. The loss of consciousness is not the most useful predictor for the seriousness of the injury. We have to look at all the other symptoms, there are the risk factors, things like that. Because let's face it, even if they weren't unconscious, but they are on Coumadin, they're getting a head scan. They're at a higher risk for a possible subdural or some type of head bleed. So while we want to acknowledge if there's a loss of consciousness, we're not going to let it make the sole determination as far as the severity goes. When you look at all their history, is this an elder? Is this an alcoholic? These people don't do as well with head injuries or have higher risks for bleeds as well too. Are there any intoxicants on board? Those kind of things. Again, medicine's Coumadin. And so it won't be like a fair test question if they say the person takes an aspirin a day for their heart protection. That's not a fair question, okay? I mean, let's face it, do we really logically think that one aspirin is going to suddenly make them have a subdural? No. Well, I'm going to say no, but compared to something like Coumadin, definitely Coumadin is a risk, okay? Or any of the other anticoagulants are out there, all right? So again, the ENA is not going to be splitting hairs, saying it's just one aspirin a day, or say they're taking, they took 400 of Advil twice yesterday for a sore knee or something. That's not a fair question. But when we add up the overall propensity of these things, or they're really present in large quantities, yes, that could make that a significant risk factor. So if they're taking like ibuprofen 800 3 times a day for 2 weeks for their back pain, yeah, that's not the same as just taking 400 of ibuprofen times 2, right? All right, so sometimes they could just be a blank stare, like they got hit in the head and they were just like staring off like that 10,000-mile gaze for a short period of time. That's a sign of concussion. It's that overstimulation again of that alert state, and their lights are on but nobody's home. So that may be all that someone witnessed. And of course, this is due to trauma, so we have to look for other injuries that could occur with it too. You know, a lot of times head and neck injuries occur concurrently. So if we're checking their head for injuries, we need to check their neck as well also. So again, back to the question, do they all need CT scans? No, not necessarily. We need to look at all the risk factors. You know, what was witnessed? What meds are they on? What's their underlying condition? What were the circumstances? Did they have a seizure with a head injury? Things like that. Okay. If they're stone cold normal, they're not on the blood thinners, they're not elder, they're not intoxicated, they're not alcoholic, there's no neurodeficits, they're completely back to baseline, they don't have any other comorbidities, that's the good risk candidate that we don't need to scan. You know, they might go home with some very close head injury precautions. But again, don't worry. For this exam, the ENA will give you someone that has the risk factors or doesn't, or has a very sketchy or questionable medical history, or the circumstances were significant. They're not going to, you know, give you that person that gray zone again. Just trying to reassure you on that, to not get so learning paralyzed about those kind of things. All right. So any head injury, whether it be a simple, you know, they were just dizzy for a few minutes after a head injury, or they're unconscious, whatever, we always want to do those neuro checks. Again, those early findings are very subtle sometimes. Okay. And then note if there's any changes, especially like doing handoffs or reports or shift change. Make sure you're really doing a good job of communicating those neuro findings, no matter how small they are, because they may be the only thing the next shift picks up on when they start to change. All right, so we're going to talk about our different bleeds now. So a concussion typically does not leave a bleed, but a concussion can occur as part of a bleed. But when we have a bleed, there's some unique things about each of these. So what you see on the cadaver is they've cut away the arachnoid tissue right about here. So they're showing us where these different layers are. All right. Now we don't talk about the pia mater. That really is just the surface of the brain. It's not really a tissue layer. It's just the surface. So we don't get bleeds underneath there, but we can get a bleed either from trauma or hypertension or stroke in the subarachnoid space. So that blood's going to flow down into these grooves. And on the CT scan, we'll see like these finger-like projections as like these fingers are going down the grooves there. Now, in the immediate head injured period, if it's fatal, it was probably a subarachnoid. So like you're in trauma, if they're in your trauma room or resuscitation room and they end up dying from that head injury, it was probably a subarachnoid. So they have the higher mortality in the immediate care phase. Subdurals have the higher mortality in the post-acute care phase, like the days or weeks later. So the subdural is the space between the dura and the arachnoid. And these bleeds tend to spread over this entire area. They don't tend to press down as much, and that's one reason why they get overlooked sometimes, because they don't present with typical dramatic, rapid neurodecline, because that bleeding, that hematoma is kind of spreading. It's not really pressing down so much. So they do get missed sometimes, and that's why they have the higher mortality post-acute phase. Sometimes also because patients don't come in right away with them because, oh, just my head hurts really bad, I'll be okay. And then not till a few days later, they start to decline. And these are also the ones that are more likely for like our alcoholics, our elderly, or people on the blood thinners, because it doesn't take as much trauma to cause a subdural as a subarachnoid. The epidurals, they occur above the dura, which is between the dura and the skull. Now these tend to form a really nice pocket, like that hematoma stays right there because that dura is like glued to the inside of the skull. And so as that hematoma starts to form, it kind of stays trapped right there. So it's more likely to press down on the brain tissue and cause neuro changes more rapidly than the subdural or the subarachnoid. Okay. Usually the epidurals take a lot of force, significant head trauma, usually skull fractures are associated with these. So I've covered these points here. And the subarachnoid, we're talking about the subdural, higher mortality overall, and can be progressive. They may not come in right away until maybe a few days later with that progressive headache, some progressive, speech changes or mental status changes. We're going to add on one other concept to the epidural though, which is called this lucid interval. What happens, this is actually so one injury happens, but there's two processes going on. At the time of the injury, they go unconscious. That's because of the concussion and that reticular activating system, okay? And by rule, concussion, you're going to come back to your baseline at some point. Okay. So, and that's the normal concussion pattern. Get unconscious, come back to baseline. Now, at the time of the injury, the blunt trauma, the epidural started, but it wasn't enough to cause a problem. So the epidural is way down here. It's there. And in the meantime, it's getting bigger and bigger and bigger and bigger. And then what you see here is when they start to crash, that point there is where the epidural is finally exerting enough pressure and force to cause them like to herniate and to go unresponsive. All right. The time between coming back to baseline and declining, that's called the lucid interval. We only use that word when we discuss epidurals because it's this unique 2-injury pattern. The first injury from the concussion, the second injury was the epidural. It was just going on slow in the background over time. Okay. And sometimes we call that the talk and die phenomenon, meaning they come back to their normal, they're walkie-talkie, they're looking good. And this is one reason some people don't go for care or to go to get checked. All right. And Natasha Richardson was the celebrity that sustained that. And that was that same pattern. She was unconscious, she came back to short time later. You know, obviously she was having a headache and some trauma, but she's like, no, I'm not going to the hospital right away, et cetera, et cetera. And then at some point she rapidly progressed and died. Skull fractures by themselves are usually not the problem. It's more concerned with the damage to the tissue is underneath there. So things like our open or our depressed skull fractures, those are a bigger concern because that bone is actually pressing down on the cerebral tissue, causing neurological findings. Okay? So if our trauma patients would shave their heads, we'd be able to see these things a little bit easier, right? If you're palpating a scalp or a skull and you feel something mushy or a hole, we're going to cover that immediately just to protect it from contamination, but we're not going to pack it or put it on tightly because that can cause the pressure to build up in there. Okay? So just something loose to protect it. Now, with our basilar skull fractures, we get a myriad of symptoms. It just depends where the fracture is along the base of the skull, the floor of the skull, depending on what nerves or what sensory or motor nerves are going through that area, what's affected. So they could present just like numbness of their upper lip, if part of the facial nerve being compressed from that fracture of the base of the skull there. So those are kind of hard to pick up on the initial exam. Other things with head injuries or skull fractures, we could have anosmia. The letter A means without. So this is an absence of smell. That's one of your cranial nerves. It's actually cranial nerve 1, the olfactory nerve. Anosmia, lack of smell. Of course, it affects the acoustic nerve. They can have some hearing problems, either absence or ringing or decreased. So again, we're not going to pack anything, even if it's leaking out of the ears, the nose, we think it's like CSF or something. We're not going to pack it. We're just going to put some light gauze over it to kind of protect from stuff going in there and contaminating. If you think you need a skull x-ray, you really need a head CT. The skull x-ray will only show you the bones. We need to see the damage to the brain tissue underneath there. Okay? And we're going to check their EOMs. All right. That's their extraocular movements. And we do that by having them follow our finger up and down, left and right. And we can also do that. So you do a plus sign and an X. Okay, you're checking all 1, 2, 3, all 8 directions of gaze, all right, for each eye. Now, hopefully the eyes will do it together and you can clear them both at the same time. But sometimes with our orbital skull fractures, the motor nerve gets trapped back there and we might notice a gaze palsy or weakness or a lack of movement in just one direction. So we want to do all those 8 directions. That's the plus sign and then the X sign. All right. And then some other head injury terms. Otorrhea means fluid from the ears. Rhinorrhea means fluid from the nose. Hemotympanum is blood behind the eardrum. We see that sometimes with the basilar skull fractures when the provider looks in the ear canal. Now, not blood in the ear canal, but behind the drum. Now, of course, they're leaking blood out of their ear. They've ruptured the eardrum also. But sometimes the eardrum's attacked and we just see like a red blood fluid line when we look in there. We might also see battle sign or raccoon's eyes. So battle sign is bruising behind the mastoid bone. And that mastoid bone is that bony prominence behind your ear. And then raccoon's eyes, that's the periorbital ecchymosis. So that's the bruising around the eye orbits. Those are both strongly suggestive for a base or skull fracture. So the fancy term for raccoon's eyes is periorbital ecchymosis. And we'll be very cautious with any tubes going in the oral or nasal cavities. So this is an NG tube. And you see, you don't see all the facial injuries, but this is obviously all messed up in here. So this is the base of their skull. So the base of their skull fracture. NG tube went in and it found the path of least resistance to this torn and lacerated tissue in the back of the sinuses, and it wound up inside the skull, and then it found the path of least resistance going down the spinal canal. So you see it down here on the CT. And on the cross section, you see that perfect circle right there. That's the NG tube in the spinal foramen. So there's gonna be some problems with that, right? Think of the trauma to the spinal canal as it went down there. So if there's any facial fractures, base or skull fractures, it's not that you can't put a tube down, but we gotta make sure it's done correctly. We need to be very cautious of that. All right, we're talking about the spine, spinal cord. So what we're talking about is these fibers that actually comprise the central nervous system. These nerves exiting are considered peripheral nervous system. We'll get to that under musculoskeletal. Right now under neuro, we're just talking about the spinal cord itself, the central nervous system. Now we've got two possible patterns with this, or two possible forces, okay? And we call them either intrinsic or extrinsic, okay? So intrinsic is just the damage to the cord. And that's like where the cord may be torn, bruised, bleeding, swelling, some edema. And those intrinsic or those secondary insults can cause more cord damage. I mean, if the cord swells too much, it's not going to be functional. The extrinsic forces are things like this broken vertebra. If it was broken and depressed and pressing onto the cord, actually cutting it, okay? That would be an extrinsic force. Typically, the extrinsic forces are easy to fix. You go to surgery and they put plates or rods there and stabilize them. It relieves the insult off the cord. These intrinsic forces are hard to treat because part of your body's natural injury response is it will swell. There will be inflammation there. There will be all those inflammatory reactant markers like the free radicals, the peroxidases, things like that. And they can cause ongoing damage until the cord is kind of settled down. So either of these injuries, whether it be the broken bone pushing into it or the swelling and inflammation, can lead to either neurogenic or spinal shock. Now, if we talk about actual damage to the cord, if we say it's completely damaged, that means there's nothing below that level. They're typical paraplegic, no motor, no sensory, nothing. It's the incomplete syndromes, the incomplete cord injuries that give us variable symptoms, okay? And we have a couple of this family. The only one that's on the exam is the Brown's quard because it follows a very specific pattern. So it makes a very good test question where there can be only one way this presents. Okay, so we're gonna go through that one. All right, and the stuff I sent you or sent as a file attachment, I think it's on a yellow sheet, maybe on a white sheet, but most times it's on a yellow sheet. You actually have these two next slides printed out for you. So Brown's quard manifests only in one specific way with a specific set of symptoms, okay? And its pathology is that it's a complete damage to exactly one half of the cord. The damage can't cross over the midline, otherwise it's something completely different. And it also has to completely come all the way to the side, because if it doesn't, it's something different. So it's a very precise injury pattern. So it actually doesn't happen a lot, but it's the only one that presents so uniquely that it makes for a good test exam question, okay? So, and this is one of those high frequency items that a lot of people, like 80–85% of people, see at least one Brown's quard question on the exam because it's so specific and so precise. So we want to be familiar with this one. Now, I don't recommend spending time memorizing the symptoms. What I recommend is making your life a whole lot easier, which is just to remember it's the only cord syndrome that has symptoms on both sides of the body. And you can figure this out when you get the question by simply drawing a picture. So during the test, if I didn't tell you it or not, you get a piece of paper, something to write on, to write down whatever you want, draw diagrams, draw numbers, draw little memory tools, whatever you want. When you get the Brown-Séquard question that you'll recognize, because you're going to hear something out, you're going to read the question, I'll have something about trauma, and you'll have all these different neuro symptoms. And they might kind of be like, they might put them out of order. But what you'll do is you'll draw like a picture of a man or a person, maybe a stick man, maybe a hangman, and you'll actually write down which symptoms are on which side of the body. And after you've gone through all the symptoms, what you'll notice is both sides of your drawing have abnormalities, but they're different abnormalities. Hence, the shaded areas are where he's having symptoms, and he's got two different colors on both sides of the body. This is the only cord syndrome that has both the left and the right affected that are different symptoms. It does not occur any other way. They can't trick you and try and move one symptom over here and one over here, because in professional exam writing, you don't do that. It's not allowed. You can't make up things that don't exist, okay? Every multiple choice answer on a multiple choice professional exam has to be a plausible answer, and there is no other presentation for Brown-Séquard. They can't make it up. So I don't even remember all these. If you held a gun to my head right now and I wasn't looking at the screen, I would not be able to remember what these are. But I can, if you give me a list of symptoms and tell me what side they're on, I can draw a picture and shade in different sides. And then say, oh, okay, both sides affected, both different colors or both different sets of symptoms. It has to be, and it can only be Brown-Séquard. And that's what makes it different from our other cord syndromes, okay? Every other one has either one side affected and one not, or it's an upper and a lower, or a front and back. This is the only one that's a complete half cord injury, very specific, with both sides of the body, but different symptoms. And also, for having taken this exam 6 or 7 times, it's the only one they ask about. Matter of fact, in your TNCC, they spend time going through this also. Right. And just another visual representation for you here. Again, I've shaded both sides of this person, but they're different shades, meaning they're different symptoms on both left and the right. And what makes this interesting, which is why it's a test question, is because it's only a half a cord damage, but you got symptoms on both sides. And there's a total explanation for this. The reason is because at the level of this injury, some of these pathways have already crossed over to the other side of the body. Some haven't, or they've crossed the cord. So therefore, you could be affecting pathways that are on both sides of the cord, even though you only damaged one half of it. So that's what makes it pretty unique there. But again, just draw a picture, label your picture, you'll see the distinction between both sides, and you'll know it's the Brown-Séquard question. As far as respiratory control, so your phrenic nerve, which is the main mover for your diaphragm, that exits at C4. Well, I put here between C3, 4, and 5. So C4 is between C3 and C5. So any damage is between C3 and C4, or C4 and C5 could potentially lead to this. So if you just remember at C4, you don't breathe no more. They're going to be on a ventilator. Okay. Now, what you hope to happen is that it's a lower thoracic injury only, because your thoracic nerves control your accessories. You'll still have your diaphragm. You just won't have that little bit extra, like to take that deep breath, or to cough when you get like a bronchitis, or so you lose a little bit of respiratory control, but your primary mover is still there. So depending on how high this injury is in the thoracic, they may not, if it's a low thoracic, like a T9, 10, or 11, they're probably not even going to have a trach. A high thoracic, T1, 2, 3, possibly. It's a very case-by-case basis, but the point is you still got your primary control of your diaphragm. Spinal shock and neurogenic shock. The big thing here is the word in spinal shock, the word shock means like a concussion. It's a temporary shutdown, okay? So this person, their cord is still intact, but the damage to it has basically turned a switch off. So while the cord is recovering and remembering what it's supposed to do, it's not sending anything down below. So if you examine them, they're going to look like a paraplegic. But with the inflammation healing up and going away and the tissue healing up, the function will come back. It's a temporary shutdown, okay? But there's no permanent damage. Now, neurogenic shock is a shock problem with blood pressure. In this case, the cord injury is again turned off, but it did not turn off the motor sensory pathway. It turned off the communication to the blood vessels. So the spinal cord cannot send a signal to the blood vessels to tell the blood vessels to stay tight, and they get big and dilated, and that drops the blood pressure. If you come into the shock lecture in one of those sessions, we go through this more in a head-to-head with a table format. You also have that table already on that yellow paper I just pointed out to you. If you wanted to look at that, you can. But we actually compare these two directly head-to-head, so you'll hear it again. But spinal shock is basically like spinal stun of the motor and sensory. Neurogenic shock is a blood pressure problem because it's turned off the control of the blood vessels, and they'll get hypotensive. And we can look at the skin also in neurogenic shock, because below the level of the injury, the skin is warm and dry because it can't tell the blood vessels to tighten up and get diaphoretic and clammy and moist. So the blood vessels don't know what to do. That's why they're dilated. That's why they're big. But again, we'll come back to this under the shock lecture just a little more in detail and make sure we drive it home. Your cervical spine injuries. So what clears a C-spine? Well, we need three things. We need pictures or images to prove that the bones are in place and there's nothing broken. All those pictures do is prove only that. They don't prove anything about the function, because remember, in spinal shock, the cord's intact. It's just turned off. That doesn't show up on an x-ray. X-rays only tell you about the solid bony structures and their alignment. So I need negative x-rays or CT, and then I need that patient to demonstrate the motor sensory. The only way I want to know their motor sensory is intact is for them to do some assessments with me. Can you push? Can you pull? Can you feel? Does this feel the same comparing side to side? Right. And of course, they need to have an absence of neck spine pain, because you can actually have torn ligaments up there. Ligaments don't show up on x-ray. And if they go home with a torn ligament in their neck and they move the wrong way, those bones can actually displace. So if your trauma patient has never woken up and you're shipping them out or admitting them, the C collar stays on, because until they're awake and alert and they can do the rest of the exam, we don't know about the function of the cord. We only know things are lined up from the pictures. We have to assess function and patient exam at some point. So three things are needed. You can actually cross off the steroids here. Okay, they are no longer a standard of care. They're not going to be an exam that was taken off, I think, one cycle ago. I just need to update my book. So you do not need to worry about that. The only thing I want you to know about steroids and spinal cord is, why did we even consider using them? And it has to do with those intrinsic forces of the cord swelling and the edema. It was thought that if we gave these high-dose steroids, we'd suppress that injury and that inflammation response and protect the cord. So just understand what the thought process was. Now, it can be done, but it's not. It used to be we'd load these people up at the moment in the trauma room. All right, it can still be done. That's going to be like secondary assessment when they get admitted, like to the trauma ICU and the neurosurgeons involved. He may do something like this, but that's outside of ER care time. So just know it was meant to suppress the inflammation that was possibly causing further damage, and maybe they'll get some function back. All right, so it's not going to test. You don't need to worry about the dose. Just understanding why we even thought about doing it. All right, our neurodegenerative conditions, and then we'll finish this up. Lou Gehrig's MS, Myasthenia, and Parkinson's. So Lou Gehrig's, so this is a, you can say idiopathic. It's not that it's idiopathic, it's just that, if you took 100 Lou Gehrig's patients, there's a likelihood that they're all going to have some different cause for this. There's not enough to be particular to say, oh, it's always a viral response. Oh, it's always due to autoimmune, okay? But the thing is, it affects them all the same, all right? And you basically have a progressive paralysis, basically from the ground up, eventually involving the diaphragm and respiratory, okay? Now, their brain function stays intact, meaning eventually they're going to wind up in some nursing home or some long-care facility, paralyzed, vegetative, but they're still awake and alert. They can still hear you. They can still see you. They just can't respond. They're basically paralyzed and awake. Okay. The most common initial symptoms for Lou Gehrig's are some tripping, stumbling, things like that. Again, as that progressive weakness and eventually paralysis comes up, they're going to have some gait problems. Now, some of them, that's most of them. Some of them, their initial symptoms are more of a central thing. They call it the bulbar onset. and it has to do with like swallowing or talking, but that is a minority of cases. It's only about a fourth. Most will be the walking problems, and that will progress. They'll eventually wind up on like the quad walkers, you know, the rollers, things like that, eventually wheelchair bound, and eventually bed bound as they're fully paralyzed and probably on a ventilator. So we don't have any fix for this. We basically just treat this person's immobility. They don't die from Lou Gehrig's, they die from being bedridden and on a ventilator. So eventually this person will come to it, and they're not going to come to the ER on the first day or two of having this, because sometimes it gets missed. I mean, okay, are there any other reasons you could be tripping a little bit from, yeah, maybe a lumbar compressed nerve or something, you know? But when the pattern's noticed by their primary doctors, neurologists, that's what makes the diagnosis. So for the CEN exam, what's their emergency? It's going to be they're already on a ventilator, they're getting shipped in by EMS from a nursing home or something, like there's a problem with their trach, or their Foley's infected and they're uroseptic, or there's an infected D-cube or bed sore, something like that. So a complication of their disease is what they die from. Eventually they'll get like septic or something. So there's no specific medicines. We just treat, and we try and, especially when they're still just having the gait problems, we try and prolong their quality of life as best we can. Once the diagnosis is made, it only goes one way, and everybody knows what's going to happen eventually. So there's a lot of family support, social services, case management, a lot of the physical therapies and such, trying to prevent complications like the contractures, trying to prevent the foot drop as long as they can, trying to prevent the bed sores with special equipment, special beds and things like that. So as far as what we'll see, it'll be they already have the diagnosis, they're coming in with a complication that eventually they're going to succumb from. Now, where Lou Gehrig's had no consistent cause, it is known that MS is an autoimmune problem. That is a confirmed fact. That's actually more common than the fact that the genetic involvement. Autoimmune, in other words, if you get a test question, what's the most likely cause? You pick autoimmune. That is statistically the most common one. And this starts with physical findings where they don't conduct the impulses well, and they present with usually like muscle weakness, fatigue, muscle pain, muscle spasm of the motor, the skeletal muscle groups. Now, they're going to lead a normal life for the most part, as far as lifespan. They don't die from MS. Whereas Lou Gehrig's, they died from a complication. MS are still going to probably live to the age of cancer, diabetes, heart attacks, whatever. MS is typically just going to be a bunch of speed bumps they have as they go on through their adult life. Now, there's some subtypes of MS that are progressive. There's some that are exacerbations and remissions. Okay. The more likely one you'll see in the ER as far as an emergency is they're having a flare-up, an exacerbation. And we're going to treat them to get them back to their remission state, or at least get back to close to their baseline. The most common initial symptoms for them are when they first present for the first time ever, and they don't even know they have it, is a one-sided one-sided sensory change of their body. Like they might check in saying, I feel numb and tingly all along just my left side of my body. Okay. Now there's, as you see, that grouping is only a third of all MS, which means all the other initial symptoms are even less than a third of the time, which also means there's a lot of other symptoms that just don't have any consistency to them. But the largest group is they'll show up with a one-sided sensory change. So for the exam, we're going to be treating them during these flare-ups, their acute exacerbations. Because it predominantly is autoimmune, that means part of what we're going to give them is steroids. Anything that's autoimmune or inflammatory, you're going to consider steroids as one of your first things you're going to do. Like the temporal arteritis was an inflammation of the temporal artery. High-dose steroids are part of this. This is autoimmune. Autoimmune diseases get steroids. Autoimmune diseases might also get things like IGs or DMAs also. Okay, but it's going to be one of those two. As far as treating the symptoms, possibly some type of pain medicine. It doesn't mean they have to be on, Dilaudid at home, but there's other pain medicines. There are neuroleptics, there's transdermal things like that. All right, but some analgesic usually, because muscle pain is part of this, and then muscle relaxers a lot of times because they get this profound contractions and twitching sometimes. So you got things like your baclofen is used commonly because it's not as sedating. All right, Flexeril is good, but it's pretty heavily sedating. And let's face it, you don't really want someone drunk and weak. okay? I want them alert and possibly weak, but at least I control their muscle pain or spasms. So you see baclofen used. Another non-sedating one, scalaxin, is used a lot of times. Robaxin, and then all three of those are not nearly as sedating as Flexeril. And this person's probably going to be on these medicines at frequent times throughout their life. So let's try and promote their function by not making them drunk and goofy all the time. Now the DMAs, those would be done probably in a neurologist's office or an infusion center, trying to suppress part of that autoimmune response. It's not something we're going to do in the ER per se, but you might hear or see they're referred to a neurologist for infusion clinic or infusion therapy for those kind of things. But we'll definitely give them muscle relaxers and steroids. Your myasthenia, so that's the chronic condition. It's an autoimmune condition again, so steroids are part of this also. And the problem here is at the neuromuscular junction. And in your muscular system, where the nerve comes from your CNS, in your muscular system, it's acetylcholine is the white drops, and they have to go over here to give you an impulse. All right. In myasthenia, the problem is they have these purple things, these antibodies that can latch onto the receptors also if the white guy is not there. And if the purple guy is on there, you can't get an impulse across. So you eventually get paralysis. So that's your myasthenic crisis. In other words, worst case, okay, so if you got a paralysis of your thigh, that's not going to kill you. But when you get a paralysis of your diaphragm, that's what we're worried about, all right, causing a respiratory paralysis. So every time you have an impulse, every time the acetylcholine comes across, you get the impulse. And after the impulse happens, the acetylcholine gets erased off of here, so the receptors open for another conduction, all right? But when the white guys are erased, that allows the purple guys to say, hey, we can get on here. We can occupy some space, all right? And when they're all full with purple guys, you get paralysis, all right? So the symptoms for myasthenia are you get weakness with increased use, leading to paralysis, and it gets better with rest. Now, what we mean by increased use means you're firing your muscle more often. Like if you're sitting here doing a bicep curl, you do them really fast, that's frequency. You're doing more of them. So something that might precipitate myasthenic crisis of the respiratory muscles is when they're breathing faster, like when they're starting to get a chest cold, a bronchitis, a pneumonia, something, an upper respiratory. You're going from your normal rate of 12 or 14 a minute to 16, 18, 20, whatever. That's firing your accessories and your diaphragm more often. So they're supposed to come to the hospital at the first sign of any respiratory symptoms before it even gets bad. Okay. And we admit them, and they'll watch their respiratory functions, hit them with some high dose steroids, trying to suppress those antibodies that are in there, because remember, it's autoimmune. And then do things like supplemental oxygen, breathing, all these things to try and get them over this respiratory thing before it leads to full paralysis. Of course, if they get respiratory paralysis, then they go on the ventilator, and those muscles get to rest, and those purple guys will kind of just wander away. So myasthenic crisis, a respiratory paralysis. The other symptom that it gets better with rest, that's because when that muscle rests, eventually those purple guys get bored and they wander off on their own. And now the receptors open again, okay? However, if you're trying to fight a chest cold or pneumonia, it's kind of hard to rest those muscles. So at some point they might say, hey, Mr. Smith, even though you're looking pretty good, your lungs, your diaphragm needs a period of rest. They might give them elective RSI and let them be like an ICU for a couple of days on the ventilator, because the ventilator is putting the air in and the diaphragm's resting, it's not firing. Okay, so weakness with use gets better with rest. The concern is the myasthenic crisis affecting the respiratory. Now, on an outpatient basis, as they're having this disease state worked up or whatever, they will probably do this Tensilon test. It's basically a test chemical to see if they respond to it. If they respond to it positively, that makes the diagnosis. So Tensilon test is used to confirm that it's myasthenia. We don't do it during their emergency care as part of their workup. Again, this is a progressive disease that builds up over time, so their neurologists will have been working with them over time, trying to really narrow this down. At some point, they'll do the Tensilon test to confirm it. Apparently you can do it to a dog too. All right, interventions for them. All right, and now if they're in respiratory rest, then we take over their breathing for them. If they come in like, agonal, fixing to go respiratory, full on rest, we can deal with that. We got ventilators. Part of their treatment is to minimize the likelihood of it getting to that point. All right, so one of their maintenance medicines is a cholinesterase inhibitor. All right, the way that works, every time they have the impulse come across here, all right, the only way the white guys, the acetylcholine, gets erased for the next impulse is acetylcholinesterase is released into this junction, and the acetylcholinesterase will go and erase the white guys each time, so you're ready for the next impulse. The problem is acetylcholinesterase does not touch the purple one, so for a brief moment, the purple ones have like free access to all these open receptors. So one of their maintenance medicines is an acetylcholinesterase inhibitor. So instead of all the acetylcholinesterase coming through here, let's hold it up a little bit. Let's only let half of it come through. So maybe it'll only eat up half the white guys and leave the other half around to kind of compete on the receptors. Okay, so we're inhibiting that normal enzyme just a little bit from erasing everything. So the purple guys have someone to fight with them. Leave a few white guys there. So those are cholinesterase inhibitors. The common drug of that family is neostigmine or physostigmine. And that's a maintenance medicine for them, trying to keep it suppressed a little bit all the time. All right. Now, they may be on daily steroids. They may be on daily immune medicines like the cyclosporine or the Cellcept, or what's the other one? I forget the other one. But definitely they come in leading up to a myasthenic crisis, those respiratory symptoms. Hey, I'm starting to get a little short of breath at home last 24 hours, things like that. We're going to hit them hard with some booster steroids, as we admit them. Okay, again, trying to suppress that autoimmune component even more effectively or aggressively. And if you do have myasthenia, you will get offered a thymectomy, because a third of the time those same purple guys that aren't supposed to be there, they can cause cancer in your thymus gland. And you don't need your thymus after you're an adult. It has to do with your immune system when you're younger and you're developing immune system. Hey, and if you don't need that gland and you have a 1 out of 3 chance of cancer, you're going to have the surgery. Parkinson's. So this is a problem of their dopamine. And dopamine is a neurotransmitter that helps give you smooth movements, smooth and efficient motor movements. So if you don't have enough dopamine, that's where we see the tremors. Okay, they're not maintaining a normal, steady muscle tone. All right, and it's tremor at rest. In other words, when they're not thinking about moving a body part, they're not thinking about raising their hand to eat or to use the TV remote or something like that. When that arm is just sitting there not being used, you see more of the tremor. As you go to use the body part to pick up the fork or pick up the TV remote, what little bit of dopamine they have is being forced or concentrated onto those motor areas. So the tremor goes away a bit. And then when they go to not using it again, putting the remote control down, that dopamine goes back to the lower level, and it's just kind of spread out through the whole central nervous system. So it's tremor at rest gets better with use. Okay. But again, the end point is it's a problem with dopamine. There's really not an emergency with Parkinson's per se, but it is something that a lot of our ER patients have either by history or contributes to other things like dementia. Maybe it's the reason they're there for a fall, things like that. So to fix this, we need to address the dopamine. They're going to be on either a dopamine replacement, meaning you're giving them dopamine in a pill form, something they're missing or they don't have enough of. That's called augmentation or replace, like adding to. All right, and that's Cinemet, which is carbidopa. Or we can be stimulating more to be released. If you think about Parkinson's like a type 2 diabetic who's both on an oral med and insulin, okay? You're giving them the insulin to augment some of their remaining bodies, and you're giving more than they need. You're giving the oral diabetic medicines like the glucophage to stimulate as much to come out of the pancreas as possible. So you're hitting it from both sides. You're stimulating or agonizing more to be released, but yet they're still having to add insulin also. That's the same thing here with the Parkinson's meds. You're giving one to add more to their body and then you're giving these dopamine agonists to stimulate more of a response from the receptors also. So you're hitting it from both sides. So you're augmenting and you're stimulating. Agonist means an agonist stimulates a cell. Those are the common medicines. The other ones there are not that common, but definitely your augmentation and your replacement and your agonists. Your GCS scale. So again, on the exam, you do not need to know the specifics as far as the numbers, but you need to know the three things we're looking at: the eye response, the verbal response, and the motor response. So there's three parameters we have to check for this. You don't need to know the specific numbers, but you do need to know the best score, 15, I think we all know that, and the worst score. I've seen this question in the exam a time or two where they ask you what's the worst, and of course they've put 0 on there. All right, if you know anything about the GCS scale, there's no zeros. So the worst score is a 3, which is kind of stupid because, you know, whoever invented this scale, why do you give the person 1 point? Why do you give them something for doing nothing, right? It's kind of like the ultimate participation award, if you ask me, where everybody gets a trophy, right? But just know eyes, verbal, motor, and then 3 is worst, 15 is best. Right there underneath there, I got about nuchal rigidity. We're going to come back to that under general medical because we're going to talk about meningitis a little bit more there. And I've actually got a slide that shows you the steps for doing that. So if you want to pull an asterisk, just saying see general medical section. All right. And then the last thing I have there for you, I don't have a slide for, but it talks about the pronator drift. So this goes back to the NIH scale. And remember I told you don't need to know the scores for the NIH, but you do need to know the things we're looking at. And pronator drift is one of the things that's kind of unique to that scale. And how do we do it? So if the patient is sitting up or they're seated, all right, then we want their arms at 90 degrees before we do this. If they're kind of just elevated with the head of the bed or they're flat, then we only need 45 degrees. So there's a difference in how you do that depending if they're straight up or if they're reclined or flat, either 90 or 45, all right? And we're gonna watch to see if one of those arms falls to the side. I think most of us have done that. I just want to put that in specifically there. I'm gonna incorporate it into the slides at some point when I redo things, but I just want to, because I saw something about checking for pronator drift. Oh, and it was about having the eyes closed. You've got to have the eyes closed. If they're open, if the eyes are open, then they can see where their arms are, and it makes the test useless because then you get that visual feedback. So it has to be eyes closed. All right.